I am Dr. Tarsheen Sethi. I'm an assistant professor of medicine at Yale School of Medicine and a lymphoma faculty member at the Yale Cancer Center. Again, I want to thank the Cutaneous Lymphoma Foundation for giving us all the opportunity to share some of these disease insights with you. So today, in this talk, I would be discussing advanced stage disease therapy options for cutaneous T-cell lymphoma or CTCL. So starting with the overview, before going on to advanced stage disease therapies, I really want to talk about what do we mean by staging of CTCL and what is advanced stage. Then next I'm going to talk about why we need so many different treatment options for this disease. And then finally, we'll go into more details about actual individual treatment options. One of the things I want to highlight, and I will highlight again during this talk, is that for CTCL patients, more than possibly any other disease I can think of, multidisciplinary management is key. That's why referral to a center which has expertise in the fields of pathology, hematology, dermatology, as well as radiation oncology, just like we have here at Yale, is really important for all aspects of diagnosis and management of cutaneous T-cell lymphomas. So starting with the staging of CTCL, what is it and how do we perform the staging? So staging provides information about how far the disease has spread in the body. And we do this by doing a physical exam, doing some blood tests, as well as imaging. The staging method for CTCL or the staging classification is called the TNMB staging classification. Here, T is for tumor, which refers to the area of the skin, type, and size of lesions. N is for node, whether the lymphoma has spread to lymph nodes. M is for metastasis, which is looking for other organs. And B is for blood, where if the blood is involved by lymphoma cells, in this case, what are known as Sézary cells. On the left of the screen here, you can see this table where just explaining some of this further. For example, when we look at the T type or the skin involvement, T1 and T2 refer to patches as well as plaques. So these are either flat lesions or just slightly raised over the skin, which are these would make it T1 or T2 disease. T3 disease usually includes tumors, and T4 disease includes erythroderma, which is more than 80% of the skin is involved in erythroderma. And then again, similarly, the lymph node, the degree or the extent of the lymph node involvement is classified as N0 to N3 disease. Presence of metastasis is described as M1 disease, and then the extent of the blood involvement makes it B1 or B2 disease if it is involved, and B0 if it's not involved. So going on to what is advanced stage disease? So as I mentioned, the TNMB classification leads to the description of these staging of the disease as to stage 1 to stage 4. And this is very similar. This, nomenclature is more similar to what you would hear about for other cancers. And early stage diseases, stage 1A to 2A. So again, as long as the skin involvement is patches and plaques, that would be considered early stage disease. Once there is tumor involvement or erythroderma, then it automatically becomes more advanced stage disease. And again, presence of metastasis or more extensive blood involvement would make it advanced stage disease. This is again just an overview to explain when I'm referring to advanced stage disease, this is what I am referring to. So why do we need many approaches for or multiple options for treatment of CTCL? The reason is that CTCL is a chronic condition. It requires ongoing care and management. It's treatable, but it is not curable. Many options that we use will put the disease in remission, but it's very likely that it will come back again and that we might need other treatment options. Patients with CTCL often need several types of treatment in their lifetime. Different approaches, regardless of the stage, they go hand in hand. And so that is, again, the reason that multidisciplinary care is not only important at the time of the initial diagnosis, but really ongoingly. And therefore, having an access to an expert center is very important. Different treatment options are also needed because CTCL is a unique disease. As I mentioned, it can involve the skin, different organs, lymph nodes, and blood. What really complicates things also is that some of these drugs work better for some compartments versus the others. And I'll give you a little bit more explanation in the next slide. So this is a table from a paper by our Stanford colleagues, and it's really helpful to explain how different drugs, which I'm going to talk about subsequently during this talk, they can have differential activity in different compartments for cutaneous T-cell lymphoma. Here, different shades of green mean that there is activity in that particular compartment. The dark green means that there is more activity than, and then lesser if it's light green. And then red means that there is limited data for, or there is limited activity in that compartment. So just as an example, we know that mogamulizumab works better for patients who have erythroderma, so that is skin involvement with erythroderma or their blood involvement, but it doesn't work very well in patients who have lymph node involvement or what we call large cell transformation. Similarly, brentuximab works for most of the other scenarios, but doesn't work very well for Sézary syndrome, which is predominant blood involvement along with erythroderma. So again, these are also reasons why this care is very nuanced. The selection of these agents require, these considerations. And then also, we do want several different treatment options because this is such a, every patient is very unique, and the presentation really determines what we treat it with. So with that, let's talk about how or what treatment options do we have for advanced stage disease. So almost all patients with advanced stage disease require what we call systemic therapies. What do we mean by that? Systemic therapies are therapies that are able to reach cells all over the body via the blood. So these can be drugs that you take in a pill form, or they can be shots given under the skin or in the vein, or what we call intravenous. So some of the different systemic therapies that are standard of care at this time are extracorporeal photopheresis, or ECP. There are oral retinoid drugs, interferons, HDAC inhibitors, antibody drug conjugates, some monoclonal antibodies, and then more traditional chemotherapy drugs. As you see in this list, the chemotherapy I have listed at the end is because there are so many targeted and different, more non-chemotherapy options that tend to be more active than a lot of traditional chemotherapy options for cutaneous T-cell lymphoma. So starting with the extracorporeal photopheresis, my colleague here, Dr. Girardi, is the one who oversees our ECP program at Yale. And this is a systemic therapy. It works well for Sézary syndrome, so patients with blood involvement at erythroderma. As I mentioned before, erythroderma is more than 80% involvement of the skin by CTCL lesions. And here is an example where you can see the extensive involvement over this patient's back. So how does ECP work? Um, so it involves drawing blood using the ECP machine. The machine then separates the white blood cells, and these white blood cells are treated with a medication as well as UV light. And then these treated white blood cells are returned back to the patient. It works in a way. It's a form of immunotherapy, and like I mentioned, it really works well for patients with Sézary syndrome, and really has limited side effects. So it's a great option for patients with Sézary syndrome, especially early on. So next, I'm going to talk about oral retinoids. So what are retinoids? Retinoids are cancer drugs that are related to vitamin A, and they can slow the growth of certain cancers, including cutaneous T-cell lymphomas. There are different kinds of retinoids available in the market for different conditions. The one that is approved for CTCL is called bexarotene, and the trade name for that is Targretin. So who do we use it for? It's for patients with extensive skin involvement. It's given by mouth. The possible side effects are high blood cholesterol, low levels of thyroid hormone, dry skin, and muscle and joint pains. So next, I'm going to talk about interferons. So what are interferons? They are a type of immunotherapy that uses a substance that has it's a naturally occurring substance that helps fight infection and diseases like cancer in the body. But in the case of interferons that we use in clinic, these are produced in the lab, and they are kind of mimic the interferons that are naturally occurring in the body. The two types that we use for CTCL are called interferon alpha and interferon gamma, with interferon alpha being the more common one. And again, it is used for patients with extensive skin involvement. It's given as a shot under the skin. And some of the possible side effects are low white count, especially neutrophil count, flu-like symptoms, fatigue, nausea, vomiting, and depression. HDAC inhibitors, or histone deacetylase inhibitors, is a class of drugs that modify cancer genes to stop cancer cells from dividing. And the two that are used for CTCL are vorinostat and romidepsin. There is another one called belenostat that is also used that I have not listed here. Romidepsin and belenostat are used intravenously, whereas vorinostat is given in pill form. We use it for patients who have extensive skin disease, and also patients with lymph node involvement can also respond well to this type of treatment. And possible side effects are nausea, diarrhea, fatigue, dry mouth, hair loss, fever, headaches, changes in taste, and low platelet counts. The next class of drugs I'm going to talk about is called antibody drug conjugates. By this, what we mean is that they have combined a traditional chemotherapy drug, and they have attached it to an antibody, which directs it specifically to cancer cells, in the hope that the normal cells in the body don't get affected by it. So one of the examples is, or the most common example is the brentuximab vedotin. It's an anti-CD30 antibody that targets mycosis fungoides cells. And this type of treatment works well in patients who have skin and lymph node involvement, as long as they're CD30 positive, or that is the cancer cells carry this CD30 marker on their cell surface. And this one is also given through the vein. The more possible common side effects are neutropenia and neuropathy, but it can also cause anemia, nausea, fatigue, constipation, diarrhea, and vomiting. Those are less common. Another monoclonal antibody that targets a specific protein on the surface of mycosis fungoides cells or Sézary cells is the anti-CCR4 antibody mugamulizumab. This one, it works well in patients with Sézary syndrome, so those with erythroderma and blood involvement. And this one is also given through the vein. Possible side effects include that when you first get this drug, you can have an infusion reaction, which can present as chills, fever, low blood pressure, nausea, or vomiting. And then otherwise, other side effects can be skin rash, sometimes more severe skin reactions, risk of infections, fatigue, diarrhea. It can cause low blood counts, but this side effect is not as common. Some of the monoclonal antibodies that are not FDA approved but can be used off label per the NCCN guidelines, and then also are being studied in other, in the clinical trials. One of them is pembrolizumab. I'll talk more about this drug during my clinical trials talk, but it's an anti-PD-1 antibody and a form of immunotherapy that basically activates your immune system to attack the cancer cells. Alemtuzumab or Campath is an anti-CD52 antibody. This one is no longer commercially available, but we are able to get it for compassionate use. It's not used as commonly for CTCL now that we have so many other options, but it is active in CTCL, and so we definitely have it in our back pocket if needed. So with that, I want to go on to traditional chemotherapy drugs that are active in CTCL. So these are usually used as single agents, meaning on their own. One example is gemcitabine. It's given through the vein, and possible side effects are nausea, vomiting, and low blood counts. Another drug is called Doxil or liposomal doxorubicin. Again, is given intravenously, and side effects include nausea, vomiting, low blood counts, but this one can also affect the heart. So we always get an echocardiogram before starting treatment. Methotrexate is a very old drug. It can be used in CTCL in lower doses, either by mouth or subcutaneously, that is under the skin shot. And possible side effects with this include nausea, vomiting, diarrhea, low blood counts, and mouth sores. The more potent, or more, in a way, a little bit stronger form of methotrexate is pralatrexate. This one is given through the vein. Again, can cause similar side effects. And we use this in the different forms of T-cell lymphoma, and the doses that we use for CTCL are lower than what we would use for some other more aggressive forms of T-cell lymphoma. And with with the supportive care that we have now, many of these drugs are well tolerated, even though they are considered traditional chemotherapy drugs. So we do sometimes use combination treatments for patients with CTCL. As I mentioned, there are so many other drugs that tend to be more effective or more active in CTCL than traditional chemotherapy drugs. However, combination chemotherapy is sometimes needed, especially in patients who have very fast progressing disease, or the cancer has changed into a more fast growing lymphoma that presents with larger cells under the microscope, what is called the large cell transformation. If large cell transformation is present in just the skin, we can still sometimes use single agent treatment. But once it involves the lymph nodes and beyond, then we really need to use more combination chemotherapy regimens. These include CHOP, EPOC, using a combination of these drugs like cyclophosphamide, adriamycin, vincristine, prednisone, and EPOC also adds on etoposide. Previously, I mentioned single agent treatment with gemcitabine. So gemcitabine can be used in combination with liposomal doxorubicin and another chemotherapy drug called vinorelbine. This is also a pretty active regimen for more aggressive CTCL. So with that, I am going to just highlight some key takeaways from this talk. CTCL is a chronic condition. It requires ongoing care and management. Advanced stage disease usually warrants use of systemic therapies. There are a number of different options that are used alone or in combination with skin-directed therapies. Multidisciplinary approach is needed for accurate diagnosis and management at each and every stage of this disease. Uh, Once a disease drug is used to successfully induce remission, it can actually be continued for maintenance of response, uh, uh, you know, uh, depending upon the case. And multi-agent chemotherapy, that is combination treatments, they are reserved for more fast-growing or what we call transformed disease, such as large cell transformation. We will be discussing the role of stem cell transplant and importance of clinical trials, which are again, for advanced stage disease in other talks today.